those I haven't met personally, I think I've met almost all of you before, but I'm Dr. Vadlamudi from the Interventional Radiology Service. So we're going to talk about stroke patients, stroke thrombectomy patients in particular, kind of a little bit of what we do downstairs, and then of course how that translates and things that we need to do here upstairs as far as post-procedural care. So just as a kind of quick starting point to kind of see what's the level of knowledge and any gaps that I can help fill, what is your understanding as far as what can be offered to stroke patients? If somebody's presenting with an acute stroke, what are some of the treatment options that can be done? You guys know?
So many more now than what we used to offer.
Okay.
I mean, you think before we'd be like, well, we're going to monitor you.
Sure.
And then all of a sudden we had TPA.
Yep.
So then that was the drug. But now it seems like in CVR, you guys be like, we're going to go in, remove that clot, we're going to put TPA right where that is, we're going to fix it all, you got blood flow, and in 3 hours you'll be fine. I mean, it's amazing compared to what it used to be.
Sure, sure. So that brings up the two kind of key points. Really, in a certain simple sense, there's only two ways of treating acute ischemic stroke, which is blockage of blood flow. One, as you mentioned, is TPA, or Alteplase is the brand name. And so that has a very fixed window when we can offer that. Really, patients who are presenting last known well within up to 4.5 hours, they can potentially qualify to get TPA. Obviously, you do a dry CT scan of the head to make sure there's not a bleed or a tumor or something else, which are not that common, but nonetheless, you want to make sure there's no reason not to give TPA, and they can potentially qualify for TPA up to 4.5 hours. Now, the other piece of things, as you mentioned, is the things we do in IR, which is thrombectomy, which what that simply means is we're physically removing the blockage. So we have to be able to get to those blockages, so those are in the larger type arteries, so not necessarily the real small branches way far away, but things like the internal carotid or the middle cerebral artery or the basilar artery, things that we can physically get to. We go in there with whether we use sort of a suction catheter, we connect it to a pump, or we use a stent on a wire, or combination. We physically remove that blockage. Now, you did bring up sort of an interesting kind of sort of sentiment of, then number one, you said something about like, well, we put TPA kind of right in that area. We actually now rarely do that. That was something that was done in the past, as far as, well, what were the options as far as treating patients? Yep, there was trials in the past that showed, well, maybe if we put TPA, or there was even earlier clot-busting medicines, urokinase, for any of you who may have had experience with it. And that was actually, yeah. but it brings an interesting point, and to sort of circle back a bit on the history of our program here, that was the first stroke intervention that was performed here at Alexandria Hospital back in November of 2000. It was intra-arterial urokinase. So, in fact, the history here is before the first IV TPA case, for stroke treatment, we actually did IA treatment, intra-arterial treatment with urokinase. In particular, Dr. Van Breda, who's our senior-most IR partner, Dr. Roll, Dr. Sterling, they really helped to push and pioneer urokinase in the legs for peripheral thrombolysis. So the idea, and there was a trial that supported it that said, well, maybe this is something we can do to help stroke patients. Because at the time, there weren't any of these tools that we have nowadays to suck out or pull out the clot. Simply, well, we could get a small catheter up there, and maybe if we drip in this clot-busting medicine, it'll open up, and it seemed to help. So that's one thing that has changed over time. So the tools have gotten better, so now it's actually quite rare that we do any kind of pharmacological intervention in the interventional suite. Now it's almost purely a mechanical thing. The parallel to kind of think of, especially given this is a CVICU, is STEMI and CATS. Way back in the day, they used to give IV TPA for patients with heart attack, right? Systemic dose of thrombolysis. Then they figured out over time, well, let's get better tools, let's get in there. It's a plumbing problem. Let's get a balloon in there, let's get a stent in there. So that's really, in a lot of ways, what we're parallel. IV TPA, it's a systemic thrombolytic dose. It goes everywhere, and you hope enough of it helps to dissolve the blockage that's causing the stroke. But now our tools, well, we go from point A to point B, and we pull out the blockage, and we open up the blood flow. So if we're getting rid of the mechanical problem, Maybe we don't need that TPA. That's sort of to be determined. That's actually under study right now. But that's where things have sort of evolved. Now, the other thing you had mentioned was, within a few hours, sometimes they're better. Sometimes that's true, and trust me, those are always very gratifying cases. I consider those like a baseball analogy. That's a grand slam. Now, every time you go up to bat, you hope for a grand slam, but you don't always get a grand slam, realistically, right? Patients some of them will do better right away on the table. Others, well, they don't, and actually probably most of them don't necessarily get immediately better. Now, that ties into, well, what are we looking for in the ICU postoperatively? Yes, we're going to do our neuro checks. We're looking for changes. One of the things I talk about to patients and their families is that day to day, and you guys see this, some days they're doing better. Their neuro exam is a little bit better. Other days they sort of seem to backslide, and it is a bit of this up and down of their neuro exam. But the real purpose of giving IVTPA up front, within 4.5 hours, or now these thrombectomy procedures, which the window is now pushed out to almost 24 hours based on some latest trials. So we really have more opportunity to help people. The real goal is their 90-day outcomes. So everything we do up front is really so that they get the best outcome at 90 days. Now I know, unfortunately, that's something you guys don't get to see in most cases. Luckily, I do see them back, both in terms of I want to see them for follow-up, but it is a privilege to see patients back, because at 90 days, oftentimes they're doing quite well. Our program here, we specifically track our outcomes at 90 days for all of those patients who have a procedure with us, and we know that that's one of the things that we need to not only track, but it's a good sign, a good measure of how is our program doing. The faster we do all of those things up front, the better we do with that post-operative care, the better those outcomes are at 90 days. And it is sometimes hard to make that immediate translation when they're not immediately moving that arm or leg. They're not sort of immediately better. It's almost, in a certain sense, very frustrating, both for of course, the patient, the family, and the caregivers, that, man, I really wish this person was doing much better. Sometimes they're not. But really, when you step back and you have that opportunity, as what we do, to see them 3 months after the fact, you see patients back, and one of the patients I remember seeing back, he came in with a devastating stroke, a left MCA stroke, couldn't move the right side of his body, couldn't speak and talk. When I saw him back at 90 days, he walked in, number one, which is great, and I asked how he was doing. He said, well, my back's been hurting. I said, well, that's pretty good that you can complain to me about your back, considering you were paralyzed and couldn't talk 3 months ago. So he didn't necessarily look at it in that same way as what I do, but then again, I see him from a sort of faraway position. So that's kind of going to, well, what are those treatment options? So just to sort of briefly go over, as I was sort of mentioning, when we do these thrombectomy procedures, most often we're coming from the femoral artery. We generally use either an 8 or 9 French sheath, so it's kind of a pretty big hole. But that being said, we most often use a closure device that can close that hole. So when they come up after our procedure, with probably more rare exception, we've used a closure device in most cases, and so they generally need 2 hours of flat bed rest because we've used a closure device. So the kind of checks we're looking for specific to the groin are Q15 minutes times 4, Q30 times 2, and then Q1 hour, basically tying into your other med exams and post-op checks. So that's sort of what we're specifically looking for, both in terms of the groin check, and of course you guys are very comfortable and used to doing distal pulses and making sure, okay, we haven't lost pulses or we haven't gotten a cold foot or something like that as a consequence of our intervention. Every once in a while, if there's sort of trouble getting from here to here, we see this especially as patients get older. The arteries here in the neck and the chest get real twisty and tortuous, and so sometimes if it's really taking a long time to get from here to here, I can't do anything in the brain until I can get a tool up into the neck. Sometimes we may come from the radial artery, and I know also you guys have been seeing a little bit more of those kind of cases because I've been doing them more in some of my elective cases. Some of the carotid stents I've been doing over the last probably 8 or 9 months, I've tended to go more to the radial artery, which is something you see, and again, we're borrowing heavily from the cardiologists, say, hey, that seems like a good route, why don't we try that? But it is, certainly an alternative access point for us, even in an acute stroke intervention, if it's taken a long time to get from the groin. I'll actually step back. Are you guys all comfortable with the kind of VAS band, TR band, the balloon, the deflation, and all that? Okay, good.
Have you seen more complications? So I remember when they first came out with those TR bands, one of the things we were worried about the most was like a compartment syndrome issues.
Sure.
Has that ever been an issue? Have you seen more of that?
Not really. No, I think one thing, and that brings up a good point, well, how are, the ways, or what are the ways that we can reduce complications, whether groin, access or radial access or any of the complications after the fact. Some of the things we look for radial access complications would be compartment syndrome, rarely, radial artery occlusion, which often can be asymptomatic. Certainly hematoma, bleeding, that's any puncture site, of course, we're looking out for those sort of things. Part of how we minimize those sort of risks in IR in general is almost no matter what, whether venous access or arterial access, we use ultrasound. So that is one of the differences. So in fact, when you look, stepping back into that sort of cardiology world, one of the issues with STEMIs and why they found there was actually decreased complication rates for radial access versus femoral access in those trials when they did acute intervention. When they're doing MI interventions, they're given a bunch of heparin, antiplatelets, agrostat, integralin, all these sort of medicines are kind of coming on board. Lots of different types of blood thinners and antiplatelets. And so more often than not in cardiology, still is sort of the case, they tend to still do access with palpation poking. For us in IR, ultrasound is not just a tool that we have, but it's actually been objectively proven to be safer. So that's why for example, if a patient has gotten TPA, I'm never worried about the fact that they got TPA, even though I'm puncturing the artery. When you look at the instructions for use for TPA or things you should not do, well, it kind of almost says you should probably not be puncturing the artery when they've just got TPA. But for me, it's not going to matter because I know my procedure needs to happen as quickly as possible regardless of whether they've got TPA. But how we can minimize our risks is, well, we use ultrasound. If I see a nice circle and I see my needle going in right on the top wall and it's right in the middle of the artery, I'm comfortable that I have, and I take the sort of 20 seconds or so to get the ultrasound to do that step, because that does translate into, again, better outcomes. Because the worst thing you want to have happen is, well, you do a good procedure up here, that's great, you get a good result, and that, again, hopefully translates into their outcomes at 90 days, but you end up with a big mess down here. Retroperitoneal hematoma, pseudoaneurysm, bleeding in the leg, maybe they need some sort of surgery in a, kind of really extreme case. So we don't want to have that, so we want to minimize that by using something like ultrasound, whether for the radial or for the femoral approach. So that helps to decrease some of those complications. Nowadays, right, it's fairly unusual to see a compartment syndrome of the arm from a radial artery access, unless you somehow perforated through, or you have, even with an extensive dissection, frankly, it's still unlikely to have a compartment syndrome.
In the beginning, it was mostly for cardiac patients,
right,
who already have vascular compromise,
sure, yeah,
and everything else too.
Yeah,
so you're looking at that.
Yeah, exactly, yeah, and that's another sort of general difference. Not to say that stroke patients don't have vascular disease. A lot of them do, because we know the risk factors for stroke are the same as the risk factors for MI and other diseases, even PAD. Well, it's hypertension and hypercholesterolemia and diabetes and that sort of thing. But in cardiac patients, generally their disease is due to atherosclerosis of those coronary arteries with an acute occlusion. In stroke patients, although atherosclerosis can be a cause for an acute stroke, it's actually less common. It's about sort of the second or third common reason for stroke in the U.S. The most common tends to be cardiac in origin, such as an AFib, so irregular cardiac rhythm causing embolus into the brain. Worldwide, though, atherosclerotic disease is the most common cause of stroke, especially in Asian populations. So that's why, by the numbers, worldwide, atherosclerotic disease, kind of like how it is in the coronaries, is actually the most common reason for acute ischemic stroke. But in the U.S., most common reason would be something from the heart, so AFib. And oftentimes, that is one of the things I actually look for on the monitor during a case. You know, I quickly glance over, and if I see obvious AFib, I kind of know probably where this thing came from. You know, versus in some cases, you know, we had a case just maybe 2 weeks ago. His case was due to a kind of second more common reason, which was actually carotid stenosis. So he had an acute occlusion of his internal carotid artery on the right side, which caused blockage of his intracranial flow. So in his case, what I did was go in, take out the intracranial occlusion first, kind of get the blood flow going to the brain, because the brain is, unlike the heart, absolutely insensitive to any kind of, it's intolerant of any kind of blockage of blood flow, which is why they have stroke symptoms. So once we removed that, then I ended up stenting his carotid artery to address the kind of underlying reason that he had the stroke. So that was not as common as something like AFib, but something we do come across. 10 to 15% of patients who are having a blockage stroke of a large artery have a carotid problem that we end up having to deal with. So that's something we keep in mind. So that's sort of some of the procedural standpoint of things. Now, in terms of the post-op, you know, checks, you know, what are we looking for, as I mentioned, outside of those neurovascular checks? Well, I think it's also important that we obviously stay on top of, you know, the MEND exams, and especially, you know, whether or not they've gotten a TPA. You know, those are the things that, frankly, that we're looking for, and, you know, when Joint Commission or anybody else external comes in, that's what they're looking for. You know, we can take very good care of stroke patients, but if we miss 1 or 2 sets of vital signs, you know, we kind of fall on our face. You know, we sort of don't end up, you know, showing the good work that we are doing. And like anything in medicine or frankly in life, sort of if it's not documented, it didn't happen, you know. And so I think that's one of the things that, you know, I wanted to also emphasize. You know, again, you guys are taking good care of these patients, but obviously, like anything, if it's not being put on paper, you know, when somebody comes to look, they'll say, well, that's great, you guys did a great case and the patient has an excellent outcome, but when we look in the chart, I can't find these things. So that's sort of some of the things we look for. What other questions can I help to address for you guys?
Is there going to be a selection of the type of patients you're going to be offering those services, or just for anybody?
Sure, very good question.
Is there age factor or stuff like that?
Excellent question. So, to the second part of your question, age is not a selection criteria. So, in essence, all of the trials that were done, I mean, granted, they were done on adult patients, so 18 and up. But for us, age actually matters not at all. What does matter, though, from a selection criteria, who should we take or not take, is their functional status before their stroke. So, the kind of buzzword we use is, were they functionally independent? So you guys will know it, okay, could they do their ADLs and IADLs, you know? Were they living at home but basically taking care of themselves, or they're coming from Woodbine, demented, and stay in bed all day? You know, that makes a huge difference. They can, as you guys clearly know, you can be 58 and be in Woodbine and not be in good shape and you know, completely dependent 24/7. You could be 98 and living at home independently. So the age, as we know, and we do see, you know, older patients, of course, is not at all a reason to exclude somebody. One thing we do from just a technical standpoint, keep in mind, is generally, as you get older, the twisty, tortuous kind of thing happens with the artery, so it may be some technical things that make it a little more challenging, but that by itself is not anything that we want to sort of exclude anyone by. So it is purely based on how were they before their stroke? Were they functionally independent? There's a scoring system that we use within stroke called a modified Rankin score. Have you guys heard of this at all? So that's sort of the more kind of granular breakdown of what, you know, was the patient's functional status. You can use it before their stroke, you can apply it after their stroke. That's what we look for example, at the 90-day mark. What is their modified Rankin score? That's what they used in these trials as far as the benchmark of how patients were doing. So it's a 0 to 6 scale. 0 is completely normal, no problem. They don't sense a problem, nobody knows a problem. You know, 1 is, often the best way to think of 1, an MRS of 1 is, the patient feels something different. you might not notice they don't have any obvious arm or leg weakness or speech difficulty, but they say, well, I don't feel exactly the same as what I was before. I have some slight but kind of imperceptible disability. MRS of 2 is, okay, they have maybe some mild, they have sort of 4 out of 5 strength, let's say, in the arm, but they're still functional. They're going to work, they can take care of themselves, but it's not 5 out of 5 strength, let's say. So MRS 0, 1, and 2 are generally kind of patients that we would want to select. Basically, hey, that's somebody who's doing pretty well before anything happened. The best we can make them is what they were. We can't make them better than what they were. You know, if somebody had some arm weakness, I can't change that, you know, as far as what their baseline was. But I want to give them the best shot to return to that as possible. 3, 4, 5 as well. Now you're talking about at least moderate or severe type of disability. Maybe they're not independent in terms of walking. They need a lot of assistance. You know, 5 is, you know, in some ways you can think of MRS of 5 as, you know, it's almost completely bed-bound, completely dependent. You know, these are a lot of these, unfortunately, nursing home patients that are really in bad shape. 6 is dead. And some, you know, patients, you know, they've expressed, I'd rather be dead than, you know, a 5, 4, you know, somebody who's in bad, sort of debilitated shape. So that's one of the things that we look for as far as the selection criteria. So it boils down to, like I said, that functional independence before their stroke, and that's of course what we're trying to get them back to. So in our book, and this is again based on what the trials show, at 90 days what we consider a good outcome is a 0, 1, or 2, meaning that they're independent, maybe with mild disability at most, but independent with themselves. So that's what we look for in the work.
So I know the focus is with the stroke patients.
Sure.
Are we going to branch out for other brain issues, such as like aneurysms? And my mother had the coil procedure done.
Sure.
So I researched and found out about that. It was very interesting.
Yeah.
And then like the scariest part was that we found that you have a brain aneurysm, and we're going to fix it, but we need that time to get to the OR, and that's the scariest time.
Sure.
So that, in the sense if you're doing it in CVIR, probably could shorten down that time.
Correct.
And you're not going to have to do a whole bunch of CTAs and get all that other kind of stuff done, and it probably would have decreased the amount of time, because there was 3 patients we saw that stroked while waiting to go to the OR. So I thought that was very interesting.
Yeah, very good question, and I'll tell you, yes, I mean, that's ultimately what our goal is right now we're taking care of sort of ischemic pathology. So whether it's an ischemic stroke or carotid or vertebral disease, you know, as far as narrowing or decreased blood flow. But of course, what comes in neurological conditions is also the hemorrhagic condition. So an aneurysm, whether ruptured or unruptured, poses a risk, of course, of a hemorrhagic stroke. Those are the minority of stroke cases. 85 to 87% of stroke cases are ischemic, but that 13 to 15% are these hemorrhagic ones, subarachnoid hemorrhage, and which are commonly associated with things like brain aneurysm. So that is ultimately what we want to build towards, which is why we want this unit in particular to be the home for neurological patients. So, you know, whether they've had complex spine intervention, or they've had carotid stenting, or they've had aneurysm repair, whatever it might be, that's the purpose of this unit kind of stepping up and stepping to a higher level of neurosciences care so that we can have a home for these patients. This summer, let's knock on wood, as long as everything stays on track, you know, we have a neurosurgeon that's going to be joining here. And so, you know, when I met with him, you know, he and I talked about, well, what are the ways we can work together and collaborate and start to do these things? Because I can tell you the reason I've been hesitant to do aneurysm coilings or other repairs is that 99% plus of the time they'll go fine. Like an elective unruptured cerebral aneurysm, you can coil it, they stay overnight and they go home, you know, and they're generally just fine. However, in that rare 1% or less of cases that they happen to rupture, either just on the table, because of your intervention, or whatever reason, then, for those who've worked in a neuro ICU before, you probably know, now they're a guaranteed 2 week stay in your ICU. They're going to need a ventriculostomy in the vast majority of cases. And so their care just really elevated to a much higher level as far as what we need to be able to do. And so part of the reason, as far as, well, why not do them at the moment was, well, one, I need to, feel confident that, well, do we have that ability to take care of them here, including having a neurosurgeon. I did plenty of ventriculoscopies during my training, but at the moment, I'm not credentialed to put in a ventriculoscopy. It's technically not that hard. You go this way 10 and this way 2, and you drill a hole and you put a catheter in. It's not that hard. Right. But, I'm not credentialed to do those things. However, those are things that I want to be able to collaborate with our onboarding neurosurgeon and say, well, let's start to take care of these hemorrhagic type patients. Let's start to elevate what we can do here in terms of just neurosciences in general. He's coming not only from a good neurosurgical training program at Buffalo, but he's doing complex spine fellowship. So part of what we want to see. And so not just the brain stuff, but complex spine work, and again, if there's ways I can help him, I'm always on board with that, as is the rest of the IR group. But that's, I think, part of what we're looking forward to. So that's all the more reason why we want to help to elevate, patient care here, kind of get these patients concentrated here, so that also, as a group, you guys are getting more comfortable seeing these neurotype patients here.
So one of the things, definitely as a CV ICU that we had a very tight-knit team approach with everything.
Sure.
And I feel that our NPs had a huge role in that aspect. Sure. If you're looking at being in that, are you looking for having specialized NPs that work in this unit with us, or will they still be within the realm of the critical care NPs, or will the neurosurgeon have his own NP? Because even before, we had a neurosurgeon a couple years ago, and he had his own NP,
sure.
and it made a huge difference,
right, just
in the teamwork and collaboration, right, and everything.
So for the moment, we have the ICU team, and then I think Emily's somewhere back. There you go, hiding away. So that's going to continue. I don't know the specifics, but I presume that when the neurosurgeon starts, he'll kind of utilize. Actually, there is already a NP or PA for neurosurgery here. Robert, you guys may probably see him, and I know he sort of helps to cross cover with IMG neurology consults and things. So there's actually somebody already in place here. So I think it's just really a matter of kind of focusing and redirecting that person or that role to, again, kind of concentrate on these neurosciences patients, kind of make sure that they're on board with helping take care. Because like you said, ultimately what we need is that team approach to take care of these patients. Certainly one thing that I want to make sort of very clear, regardless of kind of which specific patient, if there's any questions or concerns, you guys, Robin, I'm sure knows how to get a hold of me, but anytime, and oftentimes, especially for complex patients, I usually actually put a note with my cell phone number in the chart. That way it's okay, you can get a hold of me. I live 10 minutes away, and so...
I totally have questions about 2, 3 o'clock in the morning.
No, any time, because what we want to definitely foster is that if there's questions, if there's concerns, better to ask. That applies across the board, even if I'm doing something. For example, the patient that I'm going to treat today, who's going to come back to your guys' unit here, who's here the other day. I did a vertebral artery stenting on him the other day regarding his carotid disease. I said, well, I'm not necessarily planning to fix it at the time. However, I took my pictures, I examined him, I looked at MRIs. I also asked others. I asked, for example, one of my senior partners, Dr. Ken Roll, extremely experienced with carotid revascularization, both in terms of having done trials, studied it, so he has a lot of experience, and so I asked his opinion on the case, and so that's ultimately what helped influence, okay, let's go ahead and fix that carotid problem. He has what's called an ulcerated plaque, so he's got stenosis of the carotid artery, but basically there's sort of this pit of ulceration, and as you can imagine, blood swirls around in this ulceration, and things can break free and cause more strokes, and so in fact on his follow-up MRI he had a new stroke in a different area, but it relates, I think, to that ulceration, which is why I said, okay, we need to bring this, quicker rather than waiting, potentially a couple of weeks to fix it. So that's kind of one of the ideas as far as talking to more people, asking questions, soliciting opinions. I think you're never going to go wrong in asking for that kind of help. And same thing goes. If there's a question or concern about a patient, well, I mean, there's the whole point of Emily and her colleagues and the entire ICU team being around 24/7 is, well, you have somebody to come and see that patient right away. And again, I think all of them have my cell phone number, and so if they have a question, they'll call me. That's not a problem. So that's what we want to definitely foster and encourage is that, hey, we want to take good care of these patients, and there's always going to be a learning curve. I don't anticipate that right off the bat you know exactly how to take care of a patient with a dural AV fistula. Well, we have to start with what is a dural AV fistula, and then what is the pathology of that disease, and what are we looking for? So that's that learning curve. Part of it will be, of course, by education. Part of it will be by just simply seeing those patients and taking care of those patients more often. And so that's what we want to help to encourage.
Are you a protocol? If you haven't met enough ICU nurses, we're very anal retentive.
Sure.
So we like protocol. We like things spelled out and that kind of
Sure.
stuff. Have you already started thinking about like the post-op care of protocols and things that are going to happen for patients and stuff?
So I'm working with Dr. Greenberg, who's one of the neurointerventionists over at Fairfax Hospital, on some specific EPIC order sets, trying to protocol as many things as we possibly can. And also one thing I just have always done and continue to do, whether they're a cerebrovascular patient or otherwise, in my brief op note, I almost always put some kind of instructions about what's the plan. Continue aspirin Plavix, these are the neuro checks, whatever they might be, just so it's another place to look. Unfortunately, what I notice sometimes happen, this is at every hospital that I go to, even if I write it in the note, people are like, what are we doing? I put it in my note. But no, I definitely want to spell things out as much as possible. And really, in a lot of ways, whether for the ischemic or even the hemorrhagic strokes, a lot of it is quite, protocolizable, if you will. It's really sticking to those neuro checks, right?
Yeah.
What's the pressure? If it's a subarachnoid patient that's, got signs of vasospasm, okay, are we doing our sort of triple H type therapy, increasing the pressure, increasing their volume, that sort of thing. If it's
perfusion.
Right, perfusion driven, right. In ischemic stroke patients, okay, before they have an intervention with us, I tend to tell, including the anesthesia team, that, hey, I want to keep the perfusion pressure higher because they obviously have a blockage. So, I want systolics around 180. After we revascularize them, I tend to say, okay, systolic around 140, 120 to 140, somewhere in that range. Depends a bit on what's their baseline. If they're baseline hypertensive, I don't want to drop them too low. I don't want to completely normalize them. But, we kind of give them a little bit of, sort of that permissive hypertension, but not too high, because now you've opened up the blood flow. You don't want to increase the risk of hemorrhage.